All right, why is it a big deal? Well, in the US, there's at least 12,000 cases per year. Most of them are male victims, age 40s, and most are white. Interesting. Why are they mostly male victims? It's all that testosterone, that's right. Anyways, from vehicle accidents, falls, and then violence, okay? Remember that there's 33 vertebrae in your spinal column. We have 7 cervical, 12 thoracic, 5 lumbar, some sacral, and then we have some fused coccygeal bones. Cervical spine is the most commonly injured area of the spine. The second most common is the thoracolumbar transition zone. What is that? What's the thoracolumbar transition zone? Thoracolumbar, yeah, T12 on L1. Why is that? Yeah, so your spine's little at the top and it gets bigger and bigger and bigger. So when the T12 is a smaller vertebrae sitting on a more mobile lumbar, that's the second most common area. And the discs, as we know, act as shock absorbers, so they're supposed to help us. The thoracic spine, T1 through T10, is pretty rigid because of the rib cage. So it's really hard to injure that part of the spine. So if it is injured, what do you think else is injured? All your intra-abdominal and chest organs, or mostly chest and upper abdominal organs, right? It takes severe traumatic forces to injure the thoracic spine because it's reinforced anteriorly and posteriorly, so it's really hard. So if you see that, you have to have a large index of suspicion of badness. This is that transition zone we talked about. If it is injured at T12L1, which is the second most common area, usually there's not a lot of persistent neurological deficits. Why is that? At T12L1, why is there no deficits there? Yeah, because the cauda equina, or the spinal cord, already terminates around L2. So if there is any neurological injury, it's usually an incomplete one, and it's usually a bladder problem or incontinence type issue, right? Because it's so low in the spine. L3 through L5 is most mobile, and well, that's why we actually do lumbar punctures at L3, L4 typically, because we don't have to worry about hitting the spinal cord, okay? I just said this, isolated fracture of the lower L spine rarely causes spinal cord injury or result in neurological injury. If it is, it's like self-cathing type, bladder type incontinence injuries. Remember that the sacrum and coccyx are the lowest portion of the spinal cord. The coccyx actually has 4 vertebrae that are fused, and again, if there's sacral or coccyx fractures, or specifically sacral, you can have bladder or bowel dysfunction. So how do we determine what's a stable or unstable fracture? Well, we use the Dennis column system. Did you guys learn this in ortho or radiology? So basically, you got to look at this, and we have an anterior vertebral line, which is the blue line, a posterior vertebral, a spinal laminar, and a posterior spinous area. And that's what we're looking at when we look at the C-spine. And basically, if there's 2 or more columns injured, it's considered an unstable injury. Do you think that we know all of that in the ER and the trauma bay right away? No, most of the time we just assume all C-spine injuries are unstable, and we assume all people have a C-spine injury even if they don't, all right? Now usually you can actually look at the prevertebral thickness. So the thickness of the tissue, the soft tissue at C2 is around 7 millimeters, so not so thick, but it gets thicker as you get down to C7. So sometimes if you see increased thickness in those areas, it indicates swelling, which could actually point you to a possible injury. Kind of like the sail sign on an elbow x-ray. It shows any kind of swelling, and that might lead you to know that there's a fracture. So again, 2 or more columns at one region indicates an unstable fracture. In other words, if you have a injury in the anterior vertebral C3 area, but the spinal laminar area at C5, those are not concomitant or contiguous anatomically. That does not indicate an unstable fracture. That indicates 2 individual fractures. So it has to be 2 levels or 2 areas of the same level. So we assume everything's unstable, so we maintain inline C-spine immobilization or C-collar, unless we're doing airway management. Now some fractures of importance you guys will hear about, especially on board exam, Jefferson's fracture. Have you guys heard of this? So this is a C1 ring blowout fracture from axial loading. What is an axial load? top of the head. So people diving into bodies of water, that's how that happens. Or a big scaffolding falls down on somebody's head and it causes C1 to have a blowout. That's pretty bad. Hangman's fracture, that's a bipeduncular fracture at C2. Okay, that's what the arrow sign is pointing at. That's a hangman's fracture. And how does that happen? Yeah, it got its name from being hung, but it's a hyperextension injury. So it's a sudden hyperextension. So we actually see hangman's fractures in elderly people who get rear-ended at a high speed. It hyperextends the neck and they get a hangman's fracture. Pretty bad. And then there's some other fractures that we're not going to talk about, but a lot of times on the board they'll ask you about odontoid fractures. That's where if you're doing plain films, you have to do the open mouth view in order to see the odontoid view. Did you guys hear about that and learn about it? Okay, good. Then we don't need to redo it. Some stable injuries are things like a burst fracture. It doesn't sound very stable, but it's like a single level burst fracture. This happens in the elderly when they fall down onto their buttocks and all that energy is transferred up through the spine and they can blow out one of their L-spine vertebrae. What about clay shoveler's fracture? That's an avulsion of the cervical spine, usually in the C-spine. Usually it's around C6, C7, and it's a spinous process. How did that get its name? Clay shoveling, go figure, okay? But that's also where they got the term back-breaking work. And people doing those clay shoveling and then breaking their neck at C6, C7 from that spinous process. So yeah, that used to be a thing. A chance fracture, before we had the 3-point restraints in our cars, and we just had a lap belt, somebody would get hit at a high speed and it would sling the body forward. And so they would actually have a chance fracture, which is it could be lower thoracic or upper lumbar, and that's what that image is on the far right with the arrow. That's a chance fracture. But what you need to know and associate it is that a chance fracture means that they have a very high chance of having an intra-abdominal injury. So if you ever see that on the spine, you need to make sure you're CTing the abdomen because there's a chance that there's a significant bucket handle injury or tear of the mesentery or stomach or bowel. Okay, spinal cord. We talked about just like brain, there's a primary insult and a secondary cascade of things, and we treat it the same way. We got to maintain blood pressure, euglycemia, maintain the airway so that we minimize that secondary toxic cascade that happens after the initial injury. And the cord lesions, when we're talking about spinal cord, they can be complete or incomplete. Did you guys learn about this in neuro or in ortho before? When you guys learned about spinal cord syndromes, didn't you learn a little bit about spinal cord injuries in neuro? Okay, that was neuro. Okay, so complete means there's no sensory or motor below the level of injury. It's a complete injury. Patients can present with something like a priapism. That's a complete injury, all right? That's bad. And incomplete means that they have some sort of sensory, motor, or both, or at least they have some sacral sensation because it spares the sacral area, and it also spares the external anal sphincter. That's why when we do a quick primary survey, we're sticking our finger in the rectum, we're just checking for tone, and we're checking for gross blood, because we're trying to see if there's any tone whatsoever, because if there isn't, that could be a complete lesion. But usually there's sacral sparing even with complete lesions. Does that make sense? Are you with me? Did I already lose y'all? I know, it's a marathon of a morning, but you guys can get through it. You have a long weekend, you have an exam today. I mean, that's great, right? Did you guys actually have fun last night? Is that what happened? No. Oh, boring. Okay. So what's the difference between a complete and incomplete lesion? Complete means they probably won't recover from it, right? Incomplete means that they should recover some. And sometimes it's hard to differentiate if they have a complete or incomplete injury because they're also presenting with something that people call spinal shock, but it's not a shock. They should call it spinal stunning. There is no such thing as spinal shock. That doesn't exist. Shock is inadequate tissue perfusion. Spinal shock does not exist. They call it that, but it should be called spinal stunning. That's where it basically looks like they have zero reflexes. They have no sacral sparing, they have no bulbocavernosa reflex, they have nothing. It looks like a complete lesion, but what's happened is the spinal nerves are shocked at that level or stunned, and until those calm down, you can't really get an accurate neuro exam as far as how, if it's a complete or incomplete lesion. Does that make sense? Okay, because they should at a minimum have sacral sparing and a bulbocavernosa reflex. You should always have that regardless if it's a complete or incomplete. And so if they have spinal stunning and they have none of those reflexes, then you're like, hey, this is not accurate. We have to wait until those reflexes return, then do a neuro exam, a thorough head-to-toe neuro to determine how bad the deficit is. Does that make sense? Okay, remember that the spinal cord has different tracts. They have the corticospinal, spinothalamic, and the dorsal posterior column. I'm not making you guys know spinal cord syndromes for my exam since you were already tested on it in neuro. All right? So what do you think we do for spinal injuries pre-hospital? Yeah, we stabilize them. We throw them on a backboard, right? And we give them a C-collar. And we try to immobilize them as much as possible. And then they do the same things that we do for brain injury. We airway, breathing, circulation, we optimize that to try to prevent secondary injury. Now, pre-hospital, if they already know that there's an obvious spinal issue, like paralysis or a neurological deficit, they'll call BAMC in advance, for instance, and say, hey, this guy is not moving the entire left side of his body, he's got crepitus at whatever level, or maybe we had to intubate him on the scene because we suspect he had a high C-spine injury and he was having paradoxical abnormal breathing and was in respiratory distress, so we intubated him early. They'll tell us right away, and then we'll start getting neurosurgery and stuff on board right away. Just remember that C-collars can obscure neck injuries, so when they do awry, when you're doing your primary survey, you need to open up the collar. You don't have to take it off, you just open it, palpate around, back and forth, midline, and then reattach it. You want to make sure that you don't miss any kind of injuries. Obviously, just like we do any emergency department patient, we're going to get a focused history. We're going to look for a physical exam. And does it matter that the side trapezius muscle is sore after their motor vehicle accident? Do we care about that? I mean, sure, we want to treat the patient, but does that mean that there's a spinal cord injury or a cervical spine fracture? No, we care about midline spinal tenderness, midline cervical, thoracic, or lumbar spine tenderness. It has to be midline. Remember, the higher the level of cervical spine injury, the more likely they have an airway problem. What keeps the diaphragm alive at what levels? C3, 4, and 5 keep the diaphragm alive. So if they have a C-spine injury of C5 or higher, more often protocols say, hey, we intubate early. And most of the time, they will declare themselves, because when EMS arrives to those patients, they're in respiratory distress. They are not breathing normally, and they know. So they'll sedate and paralyze them deliberately, try to get a quick neuro exam, sedate, paralyze, and intubate it right away. So any level C5 or above, most experts recommend going ahead and intubating. We have to support their ventilatory function, especially if it's a high C-spine injury. And again, try to do a brief neurological exam beforehand, and then we're going to maintain C-spine immobilization throughout their continuum of care. Even if we have to take the collar off to intubate them, we're going to put it right back on and keep them immobilized. Now, I do want to talk about neurogenic shock, because neurogenic shock is a true shock. Spinal shock is not. That's why I like to call it spinal stunning. So let me say it again. There's no such thing as spinal shock. There's only neurogenic shock, which a lot of people confuse. Has anybody here ever been confused about the two terms or thought they were synonymous terms? No? Man, you're way smarter than me, because I, for years, thought they were synonymous, right? But they're different. Spinal stunning is just a temporary loss of reflexes at a level that needs to calm down, usually over 24 hours to up to a week, whereas neurogenic shock is a true distributive shock. This is where they're warm, peripherally dilated, they're hypotense, and they're bradycardic. All right? Why does this happen? Who does this happen to? Who gets neurogenic shock? Somebody with an S1 injury? What about L8? There is no L8. Okay? Is there? How many vertebrae do we have? That's what make sure you're with me. Are you with me? Okay. So who gets neurogenic shock? High cervical spine injured patients. Why is that? Because at a high level, when they're injured and the spinal cord is injured, they have unopposed parasympathetic activity. They've taken out their sympathetic nervous system high. So what happens? There's no tachycardia. There's no reflex like that, right? Instead, you get vasodilation. All you have is unopposed parasympathetic activity. So it has to usually be a high C-spine injury. It's usually C7 or above. Otherwise, lower in the thoracic spine, they can still have some level of neurogenic shock, but usually there's enough sympathetic tone at that level because it's lower that they can combat that and overcome it. So you're not as hypotense or as bradycardic. Does that make sense? No? Okay. It's usually high C-spine injuries. But if they present to the emergency department and you suspect they have a brain injury, a high C-spine injury, and they have bruising on their abdomen and they're hypotense, what do you assume the hypotension is from? They're a trauma patient. We assume it's from blood loss first. So how do I know if it's blood loss or neurogenic shock? Do I start blood products on them first? Yeah, I'm going to resuscitate with blood products until I've reliably ruled out bleeding as the cause of their hypotension. And once I've reliably, 100% definitively ruled out bleeding, then I might switch to pressors to maintain their blood pressure. And sometimes we start blood and then we're like, oh, this is neurogenic, I need to switch it to pressors. Does that happen sometimes? Yeah, it could. Usually it happens pretty quickly, but remember, our neurogenic shock patient is warm, hypotense, and bradycardic, and our shocky trauma patient is cool, clammy, hypotense, and tachycardic. But sometimes they have both, right? Could you not have both? Could you not have an intra-abdominal bleed and a high C-spine fracture? You could, so you're going to resuscitate with blood products first, okay? Just to make sure. All right, I'm going to stop here in just a moment so we won't have very many. Remember that even if you have a complete lesion, you should have some sacral sparing and a bulbocavernosa reflex. Does anybody know what that reflex is? I would love for one of you to explain it. Something happens when you squeeze the tip of the penis, right? Something happens. So does that mean that we have to have a finger in the rectum and then we squeeze the tip of the penis? That is what the bulbocavernosa reflex is. This is why we don't do it in the trauma bay very much. Can you imagine? This is something that usually happens in the ICU. And they do it when they're initially present with spinal stunning and there's no sacral sparing, no anal tone. They'll do this repeatedly on the ICU. They will do a rectal exam and pinch the tip of the penis, or in a female, you can pinch the clitoris. It elicits the same reflex, and you should feel the anus squeeze a little bit if they have a bulbocavernosa reflex. Okay, but it's just kind of a weird thing to do. The little reach around at the bedside, we don't typically do that. But if you're in the neuro ICU and you're actually monitoring somebody for improvement in neurological function, it's a true reflex that they assess for, and you can do it in males and females, okay? All right, remember I said priapism is a complete lesion, and so if they present with that, you should have a very high suspicion that they have a complete cord disruption. All right, you want me to stop or you want me to keep going? Stop? Stop, just stop. Because you're supposed to start at 10, right? You have 5 more minutes? Yep. Okay. Is your announcement going to take 5 minutes? No. Okay. I feel like people have syndrome. These people have chronic back pain or have gotten worse, okay? So I just want to plant that seed and then we'll pick up, I guess, in a whole other week and a half and talk about this. And then we'll cover fun stuff like airway management, innovation and stuff, okay? Any questions before the great announcement about anything we covered today? Okay, thank you.